The next speaker is Dr. LEILA Mohan. All of us know Madam. Madam is the head of the department of Comtrust Eye Hospital, Calicut. She'll be speaking on management of unilateral congenital cataract.
Thank you, Dr. Meena. We are talking about the challenges of pediatric cataract. Most of it has been already dealt with. What are the special challenges in unilateral cataract? It's mainly due to the late presentation because they already have a seeing eye and the deprivation amblyopia which follows, and the associations in unilateral cataracts, as Dr. Satish has already pointed out. Localized ocular dysgenesis, PHPV, ocular infections can produce unilateral cataract also, like rubella and cytomegalovirus. We have been seeing cytomegalovirus more than rubella nowadays after the immunization schedule. Often they are nuclear with posterior capsular plaques. PHPV is very common, varying in prevalence in various studies. Andrea Mullner has shown almost 100% of her cases being unilateral. And Dr. Sudarshan Kokar has shown that it is about 28 to 30% in their study among the unilateral cataracts. In our practice also we have seen, Dr. Meena was showing many of her cases with microphthalmia having PHPV, including the posterior capsular plaques. We have about more than 60% of the cases being unilateral, of the unilateral cataracts having PHPV. And amblyopia management and follow-up is critical, which is frustrating for the patient, the child, the parent, and the surgeon. I'll see you. So when should we operate in a partial unilateral cataract? When there's a partial unilateral cataract, there is no nystagmus. We want to know when should we operate. In the mild forms of dot opacities, which are very common, sutural cataracts, when they are referred to our OPD, we don't need to tackle them unless they are visually significant. So as already pointed out in the basic evaluation, the morphology, because vision cannot be tested in a newborn. In an older child, we can test telar acuity, but in the newborn, we cannot see whether he can see or not because of the cataract. So often the morphology of the cataract is taken into consideration. A centrally located cataract of more than 3 millimeter size, posteriorly located confluent cataract which obstructs vision of the macula, strabismus due to the cataract. All these are indications for surgery in a partial cataract. Of course, in a dense unilateral cataract, as already said, it has to be operated immediately at least by 6 weeks. 4 to 6 weeks is the ideal time for a good visual outcome. If you put it off, then visual rehabilitation becomes more difficult because of the amblyopia. Work has shown that the visual outcome to be as good as in a bilateral cataract if operated by this time and amblyopia treatment is instituted. In older children, surgery should be done as soon as you see them, when there is total cataract, to prevent further amblyopia deterioration. And screening is very important. As you see, this Bruckner's red reflex should be seen in the clinic of a pediatric department to rule out any new unilateral cataract. So whether we should implant IOL before 6 months is a great debate. Main challenge in unilateral cases being optical correction and amblyopia management, because the other eye is seeing. And outcome of IOL implantation before 6 months has been studied extensively. The infant aphakia treatment study group, who did a long-term follow-up of 114 children, they've already done almost going to be 15 years now. And these infants below 270 days of contact lens group and primary IOL implantation, 54 in each, 57 children in each, have been, after a long-term visual outcome in these both category have been the same, and but because the early IOL cases needed more secondary procedures, that is due to the visual axis opacification due to inflammation, and membranectomy had to be done in these cases more often. Second procedures had been more common. So they advise against IOL implantation below 6 months of age. And children in contact lens group had been given at least 9 contact lenses during a period of follow-up of 1 year in the US when they did this IATA study, which is not very feasible in our situation. And in developing countries like India, the contact lens feasibility is difficult, handling is difficult by the parent, and compliance is much less. So large periods of aphakia without any correction produces a very dense, irreversible amblyopia. So Dr. K. Kunaya from LV Prasad and others, many others, Dr. Jaspreet from Chandigarh, many studies show that IOL implantation can be done in selective cases of the newborn, the under 6 months. If the axial length is more than 17.5 millimeter, corneal diameter is more than 10 millimeter, with no anterior segment dysgenesis, IOL implantation is better because to manage them even after surgery, because you can undercorrect by about 25 to 30% in these children, because the eye grows within first 6 months, it grows very fast. Even after implanting an IOL, we have seen about plus 15 diopters remaining. So then you have to closely follow them up and reduce the power. Optical correction is very important. So implantation, of course, above 6 months, if they meet the criteria of the corneal diameter and axial length, can be done in unilateral cases, should be done, because it is easier to manage. The amblyopia management is easier, and optical correction and patching is the most important, and visual axis opacification should be followed up. And so in these cases, because posterior segment pathologies, like Dr. Meena has already said, coloboma, detachment, all these things can be there. B-scan is a must, and severity of PHPV can be seen if whether it is a dense PHPV. Posterior segment should be ruled out with a B-scan. So pre-existing posterior capsular dehiscence can be seen with an anterior segment OCT, which is not very easily available. The handheld anterior segment OCT machine is not very easily available, but if it is incorporated in the microscope, we can see posterior polar cataract, PHPV, posterior lenticonus and lentiglobus showing the dehiscence, when we can be prepared for a three-piece lens instead of a single-piece lens in the bag. So PHPV being the commonest uniocular cataract, you can see the thick plaque, very commonly seen. Dr. Meena has already shown in the faint vascular remnant is always seen in the Clockett's canal, and plaque peeling should be done for the smaller plaques, but sometimes it has to be cut with microvana scissors, or as you see here, it has to be with a vitrector instead of a PPC. It can be, you cannot pull with the primary rexus. And extensive capsulectomy and anterior limbal, two-port limbal vitrectomy can be done in many of these cases. Most of these cases, IOL implantation is possible. In vascular PHPV, as Dr. Meena has already shown, endocautery should be done to cauterize the vascular thick fibrous tissue, and then do a vitrectomy or even cut with microvanas, and then implant an IOL if the microcornea is not very severe, or better to leave alone. Majority of these cases are anterior forms. Posterior forms should be dealt with. If it is the Doppler B-scan shows vascularity, then it is better to be dealt with by the posterior segment surgeon. And sporadic posterior polar cataracts are often unilateral, and all the strategies like low aspiration vacuum, inside out aspiration, as we do in a posterior polar, should be observed. It has been seen in 7% of the unilateral cataracts, as Vasudha has shown, and the pre-existing defect may be there in 26%, and B-scan may show. So you have to be prepared for a pre-existing dehiscence, and you can still do a primary capsulorhexis around the posterior capsular opacity, and then always better to do a three-piece IOL with the posterior optic capture, where the IOL will be more stable. That is the capturing of the lens. So these are posterior lenticonus is another cause for unilateral cases. Bilateral often goes with syndromic cases, and OCT can show the integrity of the posterior capsule. Dr. Meena has already shown a video of rubella cataracts are very thick and sometimes calcific capsule, anterior and posterior. You need to put expand the eye pupil. They are quite often microphthalmic also, and all these predispose them for having glaucoma. And inflammation and glaucoma, so they should be very closely followed up. This young 8-year-old boy presented with defective vision, and after a blunt injury, and we saw that there is a posterior capsular dehiscence. ASOCT also showed this, you can see the posterior capsular dehiscence here. And we were prepared for the PC dehiscence, and often these if they come later, there is a fibrotic posterior capsular dehiscence, so they don't give way. You can manage them with the strategies to use viscoelastic soften, low parameters like low fluid vacuum, and then often we can put implant an IOL. 3-piece IOL is ideal to be implanted either in the sulcus or in the bag, and then capture it posteriorly. So all traumatic cataracts which are open globe injuries, we have to follow them up, whether they have a large astigmatism, do biometry again and again. They show large astigmatism when there is a suture. And then you have to do surgical correction. After either the suture is removed, and then do a biometry again, and then do IOL implantation. A secondary IOL can be implanted. So I'll go ahead to the... So strabismus is very common. They may present with strabismus even before surgery in unilateral cataracts, and so refractive correction should be done as early as possible. If possible, if the air is absorbed in the anterior chamber, it can be done from day 2 or 3. You may start giving glasses, and younger, and patching too. Younger children may have large residual hypermetropia, as I said. It may look just like an FAK correction in the newborn. And they need to be followed up. Maybe after another month you may have to change. So up to about 2 years you give a monofocal, after that you give bifocal, but patching is the most important. So children in IITs were followed up for 10 years, and they found about 88% of them developed strabismus, and only 50% of them had surgical correction for strabismus after 10 years. So once amblyopia improves, you can do surgical correction. And early surgery by 6 weeks, of course, and patching, effective patching has shown a good contrast sensitivity also to develop. And when surgery is done later, this may not be the same. And follow-up, as Dr. Kalpana has already shown, what all things you have to look for. Glaucoma, often they are small eyes. So all the problems of a microphthalmic eye may be there, and follow-up is important. Large myopic shift should alert you to do an EUA. Look for IOP cupping, whether IOP cupping has increased. Often these children have a very high pachymetry. When the CCT is very high, you are not sure whether the IOP is very high. So you have to look under. They have they have myotic pupils also, so it's very difficult to see the fundus. So you have to look for the disc cupping, whether it is increasing. Under GA, always better in these children, young children. So a myopic shift, which is faster than expected, also needs immediate UA. And membranectomy when there is a visual axis opacification. Secondary IOLs can be done earlier in these cases. You don't have to wait till 3-4 years as you would do when it is a bilateral cataract. So it is better to do a early secondary IOL, and always better to capture it posteriorly. This you can see the fibrotic PPC, PC opening, and 3-piece IOL has been implanted. And as all have pointed out, surgery is only the beginning. The rest of the follow-up is more important. Unless you have a good follow-up, it's of no use, especially in a unilateral cataract. I think when I did my post-graduation, there were a lot of roundtable discussions saying unilateral cataracts you will not touch, because you are not going to gain anything by doing a cataract, because unless you are very aggressive with cataracts, with the amblyopia management, you will not gain anything by doing a unilateral cataract. But now the surgical techniques have improved, everything has given us an opportunity to give surgical outcomes better, but amblyopia management is important. This is Dr. Edward Wilson. Even anywhere in the world, in US also, they have the problem of lost patients after surgery. So aggressive patching chair time is very, very important. He stresses upon this. I had the opportunity to be with him. So we have in Malabar what I would call Gulf syndrome. After getting surgery, maybe after 1 or 2 months, they ask us, let me go and join my husband and come back later. And they come with a thick membrane and maybe PL or very dense amblyopia, which is very difficult to treat after 2-3 years. And this is the early surgery. And it is always better to do an IOL if possible, because once left aphakic, it is as good. Aphakic I can see maybe 1 or 2 meters. So unless they wear their aphakic correction or contact lens, there is no point doing making a cataract to aphakia and leaving them. So post-operative management is very challenging, and counseling and follow-up is crucial. And you should look for pre-existing dehiscence and do surgical management accordingly. Thank you so much for the patient hearing.